So now I want to introduce Sandy Hassink. From the outset, when we developed this symposium, we knew it would be incomplete if the talk by a social scientist was not complemented by a talk by a physician or a health sciences scholar. I did not know who to invite, so I put out some sort of request and got a bunch of recommendations, and I got multiple recommendations from various people, including tonight's speaker, Victoria Comperis-Brown, that I invite Dr. Hassink. And when I wrote to her, I made no secret about those recommendations. Thankfully, Sandy, like Elaine, responded positively to my invitation, reinforced by recommendations from others. Sandra Hassink is a practicing physician, a teacher, and a scholar in health sciences who has published groundbreaking work on childhood obesity and more. She's also an advocate for public policy and community action to encourage Congress and U.S. citizens to do more about childhood nutrition and obesity. In examining her bio, I discovered that Sandy and I have some things in common. We both graduated from Vanderbilt University in 1978. She from the medical school, myself from the divinity school. In the school from which she graduated, there were only 12 women in the graduating class. My, how things have changed, even at Vanderbilt. Sandy also has a degree in pastoral care, a subject that I studied at Vanderbilt. Sandy's degree is from Neumann College in Pennsylvania and further demonstrates her holistic approach to medicine and health science. While I don't wish to repeat her printed biography, I want to remind you that Dr. Hassink is the current president of the American Academy of Pediatrics, a position giving her special authority to address childhood nutrition in the public realm. Knowing these current responsibilities and how busy they keep her, we are very, very pleased that she's taking this time in her presidential year to be with us. And Sandy's here with her husband, Bill, who's over here someplace in this area. Thank you. And they'll both be with us tonight as well. We will hope they'll find a brief time to enjoy Lexington. We're glad to have her here. Sandy Hassink will be speaking on building the foundations for child health, moving toward a national agenda for children. Sandy.
So you've been working very, very hard, and I wanted to just have everybody just stand up for a minute and stretch. You've been working hard, and you had lunch, and then you sat down, and maybe you're a little tired, so just let's stretch. And let's spend a moment while we're up thinking about, I've been sitting at the side, and I've been looking at the title of the conference room, and it says Leadership and Ethics. And while we're standing, I just want you to think a moment about leadership. What's leadership? And one definition of leadership is someone who is well acquainted with the current reality and can hold that in the same place with a vision of what could be, and then can lead others in the change to accomplish the vision. So congratulations, I think, for one of your steps toward leadership, because I think that's what exemplifies what you did in this summer. And I also think about the word ethics, and ethics is how we act upon our moral values. So I think in your summer program, you have really exemplified the qualities of leadership and ethics. And I really wanted to congratulate you on spending your summer giving of yourself and acting on and activating your leadership and your ethical values. So you may remain standing or you can sit down, but we're going to start the lecture. So the title of my talk today is Building the Foundations for Child Health and Moving Toward a National Agenda for Children. And I have been active with the American Academy of Pediatrics for many years, since I was a physician in training. The American Academy has 64,000 pediatricians across the country. We publish the most pediatric medical literature in the world. We have a large global presence because we develop child policy around child health, and that's activated in this country and globally. We have chapters in every state, and our mission is really to promote child health and to take care of the pediatricians and the healthcare providers who are in the midst of that child health promotion. But I was on the board of the American Academy before I became president, and I remember when I got elected to the board, I sat and I wrote myself a note, and the note said, if I ever get an opportunity to speak about a national agenda for children, I am going to do it. So I have spent my president-elect year and now my presidential year speaking about a national agenda for children. And how I always start every talk is asking the questions, how are the children? How are they doing? And you know many of these numbers, and I think we can look nationally, and Elaine certainly alluded to many of the national priorities, but 50% of our children are not meeting dietary quality standards. We have 18% of our children 6 to 17 who have obesity. We have children who have activity limitations, 9% of our children from one or more chronic health conditions. And this is a snapshot. We could pick any health parameter and look at how children are doing nationally. In terms of emotional and behavioral health, we have reports of 5% of children who are parent-reported to have serious problems with their emotions, concentration, behavior, and getting along with others. And I think particularly striking to me is our adolescent youth, who had 8% of whom had a past year major depressive episode, which is a diagnosed depression. And I think this is a very high number. We have 10% of our children have asthma. We have over half our children, and this will become clearer why this is so important, of 3 to 4 not enrolled in preschool. And as Elaine said, 48% of our children 0 to 6 live in low-income households, 200% or below poverty, and 11% of our children are living below 50% of the poverty level. So this gives us a snapshot of what's happening to children and what we might want to focus on in building the foundations of child health. Even more telling to me are our regional differences. These are by state. These are not highs and lows. These are just states I've been in lately. And this is state level data. And certainly you saw you can go down into county level data. So you see the range of childhood obesity, 26% in Oregon, 36% in Texas. Children not enrolled in preschool, 39% in Massachusetts, 68% in Idaho. Children who live in low-income houses, you see that range, 32% in Massachusetts, 55% in Idaho. Children who have asthma. And not any one state is doing all high numbers for these child health or all low numbers. But what we have here is by virtue of where a child lives, and this will become even clearer as we talk about some of the early determinants of child health, determines their current and future health. So here we are in a country where by virtue of where you're born and what your zip code is, that may determine a large part of your future health trajectory. And I think as citizens, this is unconscionable. This is antithetical to the belief that we are the land of opportunity and our children should have opportunity to achieve their fullest potential. And when you look at health factors that are really determinants of current and lifelong health, you realize children are behind the 8 ball almost from the moment they're born or even from their mother's pregnancy. So this calls us, just as you have been, to work in the wider world that calls us pediatricians to step outside our clinics and work in the wider community in the state and federal environments to understand why we have these disparities and to try to mitigate them. So this is just an example of our strategic plan at the Academy of Pediatrics, and you'll notice that we renamed our strategic plan, the Agenda for Children. We renamed it many years ago, and our tagline as part of our mission is dedicated to the health of all children. And we are dedicated to the optimal health and well-being of all children, not just to okay health or not disease, optimal health and well-being of all children. And you see the pillars there are access, quality, and finance, and that means the door should be open for all our children to enter into the healthcare system and the system that delivers health with no barriers. They should have access. Their health services and healthcare services should be high quality. We should be able to finance those so we can finance our Head Start health workers, our pediatricians, our community outreach workers at a level where we are able to maintain that quality and access in our health system. You'll see in the yellow circle that we are very concerned with health equity, and we just touched on that. Medical home, meaning children deserve compassionate, coordinated, longitudinal care with their families, and the profession of pediatrics, which of course helps our members realize that in addition to providing health services, there's a professional element to what we do, and the professional element is as health providers, we are also called to look at the determinants of health, the wider world of health policy, and called to step out into our communities. But I'll direct your attention to the boxes there in the middle. And in the past 10 years, we've had things in those boxes like tobacco, immunizations, oral health, obesity. But we've done a pivot in the last several years, and you can see some of the results of that. You see media. You see early brain and child development. You see epigenetics, poverty, and child health. And so we are moving now to address the determinants of health at the very foundational level. And when we put epigenetics, for example, on a strategic plan, many of our members were going, what is that? And I don't know how many of you know what epigenetics is. Okay, so it's filtering through. So this means that your DNA is not changing, your inherited DNA, but the environment is capable of changing the way your DNA is read out by adhering methyl or acetylhistone groups to your DNA because of environmental influences. We'll talk about this in a moment. And now you have a different genome readout than you would have had you not experienced that stress or that food insecurity or that health event. So epigenetics has given us a much more dynamic understanding of the interaction of the environment with our genomes and the ability of environmental events, whether they're behavioral, nutritional, health events, to change our DNA readout and change our longitudinal health. Early brain and child development, we'll talk a little more about that. We know how quickly children are learning, and we realize learning and experiences are actually the etiology of how your brain develops. And so a child under great stress or who has been abused has a different brain structure than a child who has not. And of course, the implications of poverty we'll delve into a little bit and talk about how poverty actually is a major health determinant. And media. And media is sort of the touchstone for what our environment is like and the drivers of behavior and the drivers of health in our culture. So we at the Academy have an agenda now that speaks to the wider socio-ecological model, our framework that either optimizes your health and all those factors or denies you the achievement of your optimal health as a child. And so this year when I've been speaking, I've really focused on what are the foundations of health for every child. And this framework comes from the Harvard Center for the Developing Child. And it would say that every child needs sound and appropriate nutrition. We need health-promoting food intake, eating habits that begin, the healthy eating habits that begin with mothers and preconception, and the mother's preconceptional nutritional status. And we'll draw those lines together, as Elaine so eloquently said, about obesity and food insecurity, are the same elements in terms of building a foundation of solid and appropriate nutrition. We also have come to learn the importance of stable and nurturing relationships in childhood and how the lack of those can allow stress to come into that child and not be buffered, and can allow the effects of toxic stress to become embedded in our biology, and we will talk about that in a minute. And of course, every child needs a safe physical, chemical, and built environment and a healthy community to live in. So the conversation that I've been having with folks this year is not about this group of children or that group of children, but what it's going to take to have every child in this country healthy. What are those elements, and then what do each specific groups of children need to achieve that goal? Because I think we're in some danger here of siloing people up, either by the health payment system they have, about the geography they live in, about the condition they have, and we are now in danger of creating a conversation where the people who have resources are being sort of dichotomized from the people who have no resources. And in reality, as a pediatrician, I can tell you, every child needs these foundations, and there is hardly any child that couldn't be helped to achieve these foundations, no matter where they live. So when we think of children's nutritional needs, and we've thought about that a lot so far, we need an appropriate density of nutrients, that it's sufficiently diverse, that it supplies an adequate but not excessive amounts of nutrition, is palatable and culturally acceptable, affordable and available year-round, and supports normal growth and development. So as a pediatrician, you know where I'm honed in is the support of normal growth and development. And I think it's so common sense to think, well, of course you need healthy food to grow and develop, but I think culturally we have lost our way a little bit in terms of thinking children will thrive and grow and develop normally no matter what we feed them. And what we feed them is embedded in this definition. They need optimal nutrition to optimally grow and develop. And you've seen the adult obesity maps in Elaine's talk, and you see the child obesity maps, and they mirror the adults. So it's not surprising that the darkest red are children who have 20% or more of children have obesity, all the way to the lightest, 5 to 10%, and you see the geographic distribution of the problem of childhood obesity. And that, as the adults, that has also evolved over the last 2 to 3 decades, and in terms of an incredible epidemic. Here's just the percent of US adults consuming 3 or more vegetables a day. Dark blue is good, so the darkest blue state is Oregon, and 35 to 45% of people are consuming 3 or more vegetables a day. Moving to the hashed lines where only 20% of adults are consuming 3 or more vegetables a day. So if you look at the adult diet and the adult capacity to either achieve that diet, bring that food home, or model good eating, you see that the children are living in families where vegetable consumption is not high. We're doing better on fruit consumption. Dark blue is good, 35 to 45% of adults consuming 2 or more fruits a day, but again, the hash line's 20 to 24%, and the white 15 to 20%. So as the family goes, so goes the child, and you see the adult fruit and vegetable consumption is very low. And if we know anything from medical research, we know fruit and vegetable intake is a marker of your ability to achieve an optimal diet and good health. You also see leisure time physical inactivity by county, and again, age-adjusted percentage of adults over 20. Now you see in the southern part, physical activity is a little higher. I think that has some climate and workforce issues, but you see that there's a lot of white on that map where only 20% of adults are getting have leisure time physical inactivity. The higher blue is more inactivity. So we have a nutrition and inactivity problem going on in the same distribution that you've seen with obesity. Now you've all seen these signs. And so what do these signs tell you about our food environment? What do they tell you? Somebody say it out loud. It's fast. So the top 10 things consumers want are convenience, 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 convenience most of the time. And consumers want it in food and healthcare and a whole lot of things. So fast tends to be very desirable. What else do these signs tell you? Yeah.
I was going to say value, like getting the most for your money, even if you really don't need to be eating that much.
Yeah, a lot of calories for your money. So when the $1 extra value meal came out, one of my patients in clinic said to me, this isn't an option for me, this is a necessity. It's a lot of calories for my money. It's convenient, it's prepared, especially if you don't know how to cook. It's very appealing. So this is the competition with the healthy food supply. What else do you notice about this food? Anything else that you notice about the actual food pictures? Yeah. What? Choice. Not a lot of choice. They tend to be very repetitive kinds of foods.
Processed.
Yes. Highly processed man-made foods. So you have cost, you have convenience, you have a highly marketed, small array of foods that are man-made and highly processed. And so in the, you saw the word palatable in the definition of good nutrition. And so would you say that these foods are highly tasty or highly palatable foods? Yeah, okay, we all know that. And we all eat them because they're that way. But in the, about 20 or so years ago, the Army became very concerned that the service people were not eating their meals ready to eat, the MREs, and those of you who are military know that they're high-calorie foods that if you're training or you're deployed, you need all those calories, and they weren't eating them, and they hired food scientists, and they said, make them taste better so our men and women will get the calories they need. And so they did, and so what was then evolved in food science was the concept of the bliss point. Has anybody heard the bliss point? The bliss point is the point at which you will continue to consume a food beyond satiety. You will just keep eating it and eating it and eating it. And they very well figured out what that point was. So these engineered foods are actually engineered, they're processed, and we could talk about nutrient content, but they're also engineered to keep you eating them. They're engineered for consumption. So if you've ever tried to pull yourself, how many people have ever tried to pull away from fast food at one time or another? Have you ever tried to pull? Most of us have, right? And then you've gone back and you've just eaten that Big Mac, or you ate a slice of pizza and you find yourself in that cycle again, because these are highly, highly palatable foods. These foods also work, and I just want to make the point where if you're a highly stressed person, all of you have heard the term comfort food, right? Comfort food? Like what we eat when we're highly stressed. It's because food induces a relaxation response and does work, and certain foods are associated with comfort. So highly stressed people tend to also gravitate to the foods. We also have seen our soft drink production in the United States increase, and it's not the only cause of the obesity epidemic, but it has increased in parallel to the obesity epidemic, and you've heard a lot now in the media about sugar and sugar consumption and how that's driving things. How many of you have seen this? Right? Where is it? Where have you seen this? Everywhere, right? Everywhere. Okay, so I defy you to find, what's one healthy thing you could eat here? Yeah, lard, pork rinds. I mean, really, this is sort of the ultimate, you can have a really good scavenger hunt in here, like find something healthy in this store. So yes, this is an extreme, but we've all been there, we've all seen that. We've all seen that at markets and gas stations and corner stores. And so this is our current snapshot of one part of our current food environment that has high exposure. It's highly palatable food. It's highly advertised and marketed food, and there you go, and it's really hard to make a healthy choice in there. So you're going to say, Sandy, why are you as a pediatrician so concerned? And I started our clinic for children with obesity in 1988. And let me tell you, in 1988, obesity was not on anybody's radar screen as far as children were concerned. And I actually was laughed at when I started. People said, why are they coming to you, a medical doctor? Why are you trying to help them with obesity? Shouldn't they just eat less and exercise more? And I remember being invited to give grand rounds, which is a medical lecture, and I drove 45 minutes one January. It was snowing a little, and I get to the grand rounds audience. It's an auditorium this big, and there were 3 people in it that came to hear about childhood obesity in 1988. So things have changed, and I wish I could say we have stopped this epidemic and things have changed, but the epidemic has really escalated to the point where we are now in a nutritional crisis with this. And why? Because people have the mythology that childhood is somehow protective of some of the adult diseases. We always associated type 2 diabetes as a disease of adults, hypertension, fatty liver disease, high cholesterol were all diseases of adults. When I went to Vanderbilt with Harlan, and I went to medical school, this was the roster of diseases you would see if you were going into internal medicine and treating adults. And I will tell you now that we see type 2 diabetes in 8-year-olds. And we see fatty liver disease as a result of obesity in 4-year-olds. And we see lipid problems in 2-year-olds. And we have 8-year-olds wearing BiPAP masks for their upper airway obstruction and obesity. And we have children getting hip surgery to put pins in their hips at 11 because of their hip disease as a result of obesity. So this has permeated right down into childhood. And when I retired to take my position as president of the academy in October, I had a clinic for under 5-year-olds, and I was seeing babies with obesity. And I will just tell you that the depression, the anxiety, the bullying and teasing, which I would have thought would have gotten less because now here all these people are suffering from overweight and obesity, has actually gotten more. So about a quarter to a third of all our children are being bullied and teased who have obesity in school with their peers, and about a quarter of them are being bullied and teased within their own families, which just then exacerbates this problem. This is a poster from one of our California pediatric chapters who began asking the question, who's hungry, and began asking the food insecurity questions in clinic. So we are starting to realize that we have a double burden on our hands. We have the burden of obesity and the burden of food insecurity and hunger, and we knew it. We just never put it together, I think, before. And if you add the children who have food insecurity, maybe 20% higher in some communities, and the children who have overweight or obesity, maybe 30% higher in some communities, and there is overlap, but we're approaching 50% of our children that have a significant nutritional health problem that is occurring in their daily lives. And so hunger is costly, and the cost is associated with chronic illness, the charity we need to help mitigate some of that, psychosocial dysfunction, diminished learning, and economic productivity. So you've heard a lot about the cost of obesity in terms of that list of chronic diseases I showed you, but the cost of hunger is also very high, the economic cost, not to mention the human cost. So you know that 21% of children lived in households that were food insecure, and 1% experienced the most severe food insecurity. And you know, those of us who see these numbers all the time, this is high. We have children in this country that aren't exactly sure where their next meal is going to come from and are worried about food, and are in families that are worried about food. So in Boston, when they had the snowstorms this winter and children were not in school, children were not learning, they also were not eating. And children, we have summer feeding programs that are not at the level of our school nutrition programs, so children are hungry in the summer. And so the hospitals that are having summer feeding programs and the churches that are having summer feeding programs, very important because we are having hungry children in the summer. And these are more food insecurity questions, and I just feel if you think a moment about people who are worried the food would run out, or that the food they bought did not last, or they couldn't afford a balanced meal, or they cut the size of a meal, or they cut or skipped a meal in 3 or more months, or they ate less than they felt they should eat, or they were hungry but didn't eat, or they didn't eat for a whole day, or they didn't eat for a whole day in 3 or more months. These are significant challenges to anybody trying to have a job, raise children, live their life. This is a significant challenge when you are burdened by this. So we saw about the health conditions of food insecurity, and I won't belabor that, more anxiety, depression, and school difficulties in addition to the physical problems, more difficulty with interpersonal skills, self-control, attentiveness, flexibility, and persistence. So boy, if you were in the education system, you would really want to mitigate the effects of food insecurity. And the last bullet is just, for very painful to me to even have to stand here and say that we may have food insecure infants in this country who are more likely to have insecure attachments and perform more poorly on cognitive assessments at the time when their brains are in their most rapid growth stage. So I think for a healthcare provider, for a physician, this is profound. So we do have federal food and feeding programs, and we are in the sort of unimaginable position, at least to me. I've been up in the Senate and I've done Senate hearings and we've testified and we've talked to committees because we're having to defend food and feeding programs. We're having to defend the gains we've made on the school, the Healthy Hunger-Free Kids Act and school meals. We're having to defend the integrity of the WIC program. We're having to defend the dietary guidelines. So this is a real challenge for us at this point, for the whole community. We are asking our physicians to make sure that if patients are eligible for feeding programs that they sign up. And there are many reasons why they might not have signed up, but at least make sure that if you're eligible, you have access to that food. So we really have a double burden here of obesity and food insecurity, and as Elaine said, sometimes they've been seen as separate and sometimes opposing entities, and they coexist. So on the global standpoint, there are more children who have overweight and obesity than children who are malnourished globally. They coexist nationally, as you've heard, they coexist locally. They coexist within families, hungry people and people who have overweight and obesity, and they can coexist even in the same individuals. So people who have been malnourished as children will end up being stunted and shorter adults, and those moms, if they've been stunted and malnourished as children, will have babies that are more prone to have obesity, and those moms themselves who've been stunted in childhood are more likely to have obesity. So this dual burden is simultaneously occurring in our population and affects almost 50% of our children. And the picture, and this is a hard thing for people to understand, again, that you can have a child with obesity who's also suffering from food insecurity. But the conditions that promote both of those are overlapping. And the challenge here is having dependable access to high quality food. And so 16.7 million youth younger than 18 do not consistently know when or how adequate their next meal will be. And these are some of the conditions, as you've seen, that lead to both of these: limited resources, lack of access to healthy, affordable foods, fewer opportunities and poorer opportunities for physical activity, the cycles of food deprivation and overeating, high levels of stress, greater exposure of marketing of obesity-promoting products in poor areas, and limited access to health care. So these are the overlapping things. And I just want to share with you some of the strategies. They're not identical, but they're so close. And so our job here is to merge the strategies that ensure basic healthy nutrition so we can take care of the nutritional crisis we're having. So we see education. We see family-based skills in education and lifestyle modification. We see supplementation. We see interaction with clinical care, how to scale up food delivery systems and programs, strategies at a policy level to deal with poverty. All of those would help improve both situations for children. Certainly schools are a focal point and have been a focal point for much of the work we've all been doing. And you see there school lunch and breakfast, quality snacks, alternate feeding venues for summer feeding, identifying infants in early child care and education with food insecurity, and then the whole health environment of the school, optimal food, phys ed, using healthy foods for fundraising, paying attention to health education and the built environment. So we have a suite of strategies that we can be implementing together to make sure we can tackle this problem. And at the community level, it starts to synergize a little more. So we have our efforts with the healthy built environment and healthy community. And think of this: a healthy built environment where you can walk in your community also, if you had access, might increase your access to healthier foods in a safe way. So these things are synergistic: employer support for nutrition and activity, and the state and national food and feeding problems. So we have interventions we know work. I think what we lack here is enough societal will to push the ball over the finish line. Now I'm going to talk about one of the other key foundational issues of child health. And how many of you heard of the Adverse Childhood Experiences Study? Okay. So Dr. Folletti had 17,000 adults who had obesity. He followed them. He asked them simply, what happened to you when you were children? So what happened to these adults was they had high levels of emotional, physical, and sexual abuse, and I think you can see those levels are very high. They had high levels of household dysfunction, mothers treated violently, household mental illness, separation or divorce, an incarcerated household member, and later he began asking about emotional or physical neglect. So all of us, and I want to correct myself, these were not just adults with obesity, these were adults in the Kaiser Permanente health system. So all of us could look at that and say, wow, this is a lot of problems these adults had as children. But what really, where the rubber really meets the road here is these adverse childhood events had a graded relationship to the presence of adult disease. The more of those adverse childhood events you had, the more likely you were going to have ischemic heart disease, cancer, chronic lung disease, fractures, or liver disease. The more adverse childhood experiences you had, if you had 1, 2, 3, 4, the more you had risk factors for chronic disease. You were a smoker. You had alcoholism, promiscuity, obesity, and substance abuse. The more of those events you had, more relationship problems, high stress, job difficulties, poor self-rated health, early pregnancy, poor mental health, more depression, sleep disturbances, anxiety, poor anger control, and memory disturbances. What was happening? What was happening is, what happened to you as a child was somehow embedding itself in your biology, both your physical and psychological framework, and predisposing you to the chronic disease problem we are now having in this country. So we know that the stress response, you just finished you're gearing up for final exams. What's happening to your body? Your blood sugar's going up, your blood pressure's going up, your epinephrine's going up, you're in that fight mode. The exam's over, you relax, you calm back down. People under chronic stress are always in that fight mode. Their body's always pumping out cortisol, pumping out epinephrine. Blood sugar's a little higher, okay? So those chronic stressors of childhood are setting your system up to respond with the stress response more of the time. We also can see that we have the preconceptual exposures to adult life exposures, that we have vulnerable periods in our biology, like intrauterine period, early infancy, probably puberty, and pregnancy, where these experiences, you're more susceptible to embedding these experiences in your biology, possibly through epigenetics. That's how we think some of the mechanisms work, is that these experiences affect your biology, change the way your DNA is read out, change the way you're going to respond across the rest of your life in terms of your own health. Now we see here that we have the brain and we have the synaptic connections, and we all know at birth we have many fewer synapses than we do when we're 6, and then those synapses get pruned based on our experiences, so that we have sort of the adolescent brain, which is still evolving until you're 25, so don't give up. Your brains can still have time to evolve. But what happens is, did you ever think about what stimulates brain development and synaptic growth, those little connections? Our experiences do that. So the quality and suite of experiences we have are actually modeling, our brains are modeling on those experiences, and different synapses are forming than would have formed had we not had them. So those toxic stressors that are not buffered, those little brains are different brains than they would be if they didn't have those toxic stressors and those adult experiences. And those brains are making decisions as adults about health and health behavior and risk-taking. So we now know that a mother who has diabetes in pregnancy will have a child more likely to develop obesity and diabetes because of the altered intrauterine environment. We now know that children exposed to adverse childhood experiences and develop toxic stress will have changes in brain maturation and functioning. And we now know that if poor early infant feeding patterns, if they persist and those food choices persist, is really predisposing a child to chronic disease. So what happens here? We know that what happens to a child, and we all know this, is very important at that moment, what happens to that child, and as physicians and healthcare providers and educators, we respond to that moment, but that moment's also incredibly important for the rest of the child's life. Now, can these be reversed and mitigated? We hope so. We hope that these stressors, and there's some research to indicate that if you have a good relationship in your family, those adults may buffer some of these chronic stressors that you have. If you have adults and you can identify the adult stressors and help the adults modify their stress, they act as better buffers for the children. If you can help the adults become sensitive to the child's needs, a highly stressed parent who has their own set of adverse childhood experiences possibly, who may be highly stressed, who has poverty or food insecurity, may not be able to respond as immediately to the needs of a child as they would otherwise. And then help the parents identify how to help parent in a way that reduces stress by helping with temper tantrums and child's behavior and emotional outbursts. So there are things we can do, but what about these things? These are all, what's the quality of all of these interventions? What do you notice about each of these bullets? It's not connected with pharma or drugs, right? These are relational interventions that we can do with families and children to help mitigate this stress. How many of you had these kinds of things happening to you as children? Look at this list. How many of you had these kinds of things? Shared feelings, playing together, expectations and structure, protecting you from adult concerns, encouraging steps to small goals, trying something new, keeping healthy, trying something relaxing. These are all parent-child best practices that can help buffer the effects of toxic stress. How many of you met children that didn't have a lot of these going on this summer? Right, didn't have a lot of this going on. Okay, so we want to work hard to mitigate these toxic stresses, but we also want to be working to help people discover the relational importance of this buffering that can happen with children. You might have noticed we also have poverty on our agenda, and why now? Well, the poverty threshold has not kept pace with the rising cost of education, housing, or healthcare. We know we have high percentages of children in poverty. We have and it's growing, and we have the highest poverty rate of percentage of children in poverty among industrialized nations. So poverty, again, if we're looking at problems that spread across the child's environment, the socio-ecological environment, poverty is one of those problems. And poverty disproportionately affects adults. So you can see on this slide the seniors who had high rates of poverty, they're the blue bars. In the 1950s, we had anti-poverty programs, we had Medicare, we had health care, took care of a lot of their poverty issues, and they were actually higher than children. And now we have affected their poverty through policies and practices. We haven't yet been able or been focused in the way we focused on seniors, on children, to reduce their poverty levels. Race and ethnicity magnify the effects of poverty. Race and ethnicity magnify the effects of chronic illness. So we know we still have incredible disparities to deal with in this country, and you've all experienced that, I think, this summer. And as a physician, you could say, so Sandy, why are you interested in poverty? Because there are diseases that are increased in our children with poverty: asthma, obesity, dental caries, injuries, mental health diagnoses, HIV infections, tobacco exposure, to name a few. So even if you just look at the pure health relationship of poverty, we have a gradient across poverty of health problems in our children. So we are asking our physicians to know their communities, to ask the 2 food insecurity questions, to know where their food banks are, to ask people with their children, are they enrolled in federal feeding and food programs, and to screen for key poverty-related health conditions. Meanwhile, while we are looking at policy solutions, but our physicians want to know what can they do right on the ground. We have food pharmacies in some of our adult hospitals where a patient who might have had surgery and food insecurity is being discharged home. And everybody knows you need good nutrition to heal, and they don't have food, so they'll go to the food pharmacy and get food to take home. We have one clinic in South Dakota who actually was looking at infants, families with infants who had food insecurity, and realized a lot of those families were stretching formula, and started carrying formula in the clinic to supplement. So we are beginning to try to draw these lines together between food, poverty, health, toxic stress, and really work across the socio-ecological model. Have you heard the term population health? Population health has become really popular in terms of how we're conceiving of how you raise the level of health so that the healthcare cost burden in this country is not crushing us. So this means a couple of different things. One is, what is the health of our communities and the whole population? And then from a physician standpoint, how can I manage my whole population of patients to get healthier? Do I know how many children have asthma, obesity, food insecurity, and can I manage the entire population to get healthier? We know, as we've said, cumulative risk occurs across the life course, so these sedentary behavior, smoking, and obesity start early, and you just accumulate that risk, and so early starts invoke an impact on longitudinal health, but prevention can be cumulative, and we need to be thinking about how we invoke our ability to do preventive medicine all along the life course at a population level. You know, we've been working in the community a long time in the Academy of Pediatrics, helping our physicians with small grants to get into the community, to identify what kind of community work needs to happen. And I think for all of us, all of you who've been in communities know it's important for all the stakeholders in the community to begin speaking about what their joint goals are and how their work might connect and how we create a strategy for change. I have a large concern about quality here, and I worry that children in poverty or children in one part of the country will not be getting the same quality of health and health care as other children. How might we use community-level data, integrated electronic medical records, data systems to ensure that we're delivering quality wherever that child ends up going for health care, or wherever that child ends up getting a preventive health intervention? We have to be speaking to each other and connected to each other to make sure every child has access to that quality. And then as child health goes, so goes the health of our population. So I think it's really, at least to me, obvious at this point that it won't necessarily matter what kind of intervention we have in terms of population health at the adult level if we cannot guarantee a healthier population. And this is the health cost. This is our future workforce. So many of you may have heard of Ready Nation. It's a group of retired generals who have gotten together and said, you know, only 25% of our young people can actually qualify for military service. If you take away obesity, high school lack of high school education, and criminal records, that leaves 25% of kids that could qualify for military service. And you can think about that, or you can think about how might this health burden impact our civil infrastructure, our police and fire, our EMTs. So we have a community stake in this, and a national stake in this, and a community health stake in this. And then again, how are we going to partner across disciplines? So I really like the fact that across disciplines, we're now speaking about the same things, trying to figure out how can we join hands across traditionally siloed disciplines of maybe medicine, economics, social science, corporate leadership, and really get focused on this problem. And this sort of reflects the kind of work we're all going to have to engage in is looking at all the sectors that are involved and speaking across those sectors. And I think it's important when you speak about children, everybody will nod when you say, are children important? Yes. Are we committed to children? Yes. And then we get to a certain point in the conversation where money and return on investment becomes important, and children kind of slide off the table. So wherever we go, as pediatricians, we are, and people who care about child health, we are trying to keep the children on the agenda at all times. So I was in at the Senate celebration of the 50th anniversary of Medicaid this last week in Washington, and we were all sitting around the table, all the the people interested in healthcare and the Medicaid program, and speaking to the senators, and I was the only child person in the room. And if I hadn't been there, children would not have been mentioned because there's so many other considerations. So I think we have to really focus on the fact it's not to keep children on the radar screen. And then advocacy. And I think you may not know it, but you've all been advocates this summer. So advocacy starts when you speak one-on-one with a person in a community or a patient or a family about their situation, about how to improve their situation. That's advocacy. Advocacy is when you get together like this in a group and you share your stories and you share how you might have advocated for your families or what opportunities might exist for future advocacy. Advocacy is when you're telling your stories about the families you've met to your legislators or your professors or the leaders in your community. So in that way, you have all joined the advocacy effort here to improve health. And it's that blending of your direct experience and your ability to relate that experience to others, blended with the evidence you know of what works and the possible policy solutions or community solutions that might exist. So you have all been advocates this year. And we're back to leadership again. And I think that as leaders, and I think I include all of us in the room as leaders, we need to be willing to step out and take leadership. And this also involves leadership, thought leadership, and being willing to think about the problems that our children face, speak about those problems, and advocate about those problems. So I thank you very much for your kind attention today. Thank you.
Instead of taking time right now for questions, we're going to have a time where they're all going to be sitting here in front of us, and we'll be able to ask questions of the entire group. So we'll do that, and we'll take a little break right now. Before we do that, however, I want to make sure that those of you who didn't get a chance to meet Jonathan Wortham last night, meet him now. He's a physician at the CDC, a former student at in the poverty program at Washington Lee, and I wanted to thank Jonathan again for, Jonathan, you can stand. Thank him again for being here last night. Help us.